Welcome back to another episode of the Braun Performance and Rehab Podcast, powered by ISOFIT and Firefly Recovery. ISOFIT is my go-to for all things isometric strength training. For more on ISOFIT, be sure to check out ISOFIT. Episodes like this are made possible by Firefly, the official recovery provider of the Braun Performance and Rehab Podcast. For more on Firefly, be sure to check out recoveryfirefly.com. This episode is powered by Dr. Ray Gorman, founder of Engage Movement. Learn how to boost your income without relying on sessions. Get a free training on the blended practice model by following at Ray Gorman DPT on Instagram. Dr. Scopp, welcome back to the podcast. It's so great to work with you again. For people who aren't familiar with you and all the incredible work you're doing in the space of orthopedics and sports medicine and joint preservation, would you mind filling them in a bit about who you are and what your practice entails?
Yeah, Dr. Jason Scopp. I work with Peninsula Orthopedics as the director of the Joint Preservation, Sports Medicine, and Biologics Institute. And so even just the whole discussion that we're about to have, Biologics has basically penetrated every aspect of sports medicine, whether it's surgical or non-surgical optimization. And so this will be a great way to kind of dive into that. I've been here since 2003, honored to take care of Salisbury University, a lot of local high schools up and down the coast from Virginia all the way up to Lewis, and then the Delmarva Shorebirds, and then all the lacrosse. And so I've got a lot of vibrant activity kind of register here. And then, of course, pickleball, and so which sort of permeates every age group. So yeah, and biologics really has become sort of it's not the newest frontier for me because we've been using it for a while, but it seems to have caught on with the athletic and non-athletic population.
Absolutely. I feel like now more than ever, people don't just want results. They want them immediately or as quick as possible. And, take like the ACL rehab game. It's like a lot of people, 9 to 12 months is just not feasible anymore. They want to do it in 8.5. They want to do it in 8. They want to push the envelope that way. Same thing with your non-surgical patients, right? When something hurts, well, we want it better quick. Yeah. And I think that biologics, at least in my opinion and my understanding, is trying to push the envelope of what's possible from a traditional healing timeline and traditional physiology timeline. It's like, hey, can we do something very targeted and specific to try and speed up this process, whether that's decreasing inflammation, improving tissue healing and regeneration, and so on that way. I mean, so much so that some of the different orthopedic providers that I've talked with have told me that, when they do isolated meniscus repairs, they're not just like doing the meniscus repair. A lot of them are injecting something into the joint. It's probably something that you're going to know a lot better than me, but essentially they told me that when they do bone tunnels for an ACL reconstruction, it floods the joint space with all kinds of beneficial things, and meniscus repairs are more likely to heal successfully than if they are repaired without that kind of bone tunnel and whatever growth factors is released from the bone into the joint space that way. Obviously, this is an area that's complex, and I don't have the best understanding of it myself that way. When someone comes into you asking about some kind of biologics or joint preservation type of thing, whether that's cortisone injections or PRP or stem cells, where do you kind of start that person with in relation to this complex world of biological medicine that way?
Yeah. So, it's a good question. That's a lot to unpack. First, just the one thing, cortisone is the one thing that is not joint preservation. It's actually joint destructive, but we do use it as we need to. And I'll use it as sort of the first step sometimes as we're trying non-operative optimization, but going down what I call the biologic menu, everyone thinks it's stem cells. And so we kind of have to, whenever I have a discussion with a patient, we have to just make sure we're talking, comparing apples to apples and oranges to oranges. And, saying everything is a stem cell is like calling every soda Coke. It's all of the big umbrella is actually biologics. And so some patients know that I do it, and they come kind of specifically for that. And then some patients don't know that it exists. And then we kind of have that discussion as we're going through, managing their pathology. And so So that said, let's say I have a 58-year-old pickleball player who has a history of a knee scope 10 years ago, partial meniscectomy, X-ray shows some joint space narrowing, and they get activity-related pain. And we kind of have this discussion. We'll say we'll do an unloader brace. We'll, talk about some various, activity, things that you can work on. What I like the core to the floor kind of generic concept, but also how we can manage the joint internally. So that's where we have the discussion of biologics. Biologics is the umbrella term, and under which you can talk about stem cells, and we can talk about platelet-rich plasma. We can talk about a whole bunch of other things that are deeper dives, probably beyond the scope of this, but things called exosomes, A2M, and things that will be on the horizon that just aren't there yet, that we do use at times as we're trying to fine tune what we're trying to accomplish. So then it really comes down, and then of course there's amnion or amniotic fluid and placental blood and those sort of things, which people think are stem cells, but actually not any cellular components to it. So then so that's the first step. So is the discussion. Then we talk about, what is best for that patient. To date, 2025, the most tried and true and the most powerful way of managing, let's say, this kind of 53-year-old, slightly degenerative varus athletic guy like me is PRP. PRP then actually outperforms stem cells. Outperforms the other components we talked about for this management of kind of arthritic non-operative care. PRP then is even more distilled down, where we can actually, with a machine that we use called the Angel machine by a company called Arthrex, that allows us to actually really personalize what we're trying to treat. And it allows me to choose what type of cells I want or I don't want. Do I want neutrophils in it? Do I not want neutrophils? Am I trying to get inflammation because I'm treating a tendon issue, or am I trying to eliminate inflammation because I'm treating arthritis? And so then we talk about, again, what we're treating, and then we talk about the treatment, and that gives us to platelet-rich plasma. And I tell patients, that 53-year-old patient, I say, you can expect, if you respond, you can expect 6 months to 1 year of pain relief from a single injection. The old data and the old sort of reason why it's not covered by insurance, and insurance companies love denying it, is because the old data was all over the place. People didn't know the cellular components, so we couldn't fine tune it. We didn't know leukocyte rich, leukocyte poor. How many, is it? There's different types of spins. Something called a Buffy coat, something called plasma derived. There were so many variables, and so the data was all over the place. But the data is better now. And I'll take a breath and see if you have a follow-up question before I keep going.
Absolutely. There's a lot to unpack from what you already mentioned. And it sounds like from what you've outlined, cortisone might be a potential like short-term pain relief option. But outside of that, it's not really something that we want to be putting at the main seat at the table here, especially going back to what we talked about in our last podcast episode. It's like, I don't want to just concern myself with what this knee looks like for the next week. I want to know, is it going to hold up to activity for another year, or potentially the length of an athlete's career? And unfortunately, a lot of the time, those cortisone injections just don't seem to fit that mold quite as well as we want them to. But it sounds like, based on what you've shared, there's a whole emerging world around the PRP that just hasn't necessarily existed in the past. And it's interesting because, just like you mentioned, there's been a ton of people I've talked with that have phenomenal experiences with PRP. They credit it with all these improvements and relief, and just it's the best thing ever. And then I've talked with others that say, yeah, it did nothing for me. I just spent $2-3 grand and I feel like I got nothing from it. But it sounds like the art of PRP is in the orthopedic provider that you trust to provide that to you, and their ability to get the unique combination of what you need, whether that's the spin rates and spin cycles to the cellular components of it, correct, based on your own physiology and the type of tissue that you have injured in the first place that way, because as you mentioned, it sounds like it has a wide array of applications from your, within the joint itself applications all the way up to tendinopathies and kind of everything in between that way by the sounds.
And the problem when I hear like when someone says they didn't respond, there's so many reasons why they couldn't, right? If they have KL4, bone on bone changes, it's not going to work. If they didn't follow the kind of strict guidelines pre and post injection, it's not going to work. If their provider does not know, the uniqueness of this biologic menu and what is right for what patient, it might not work. And so there's so many variables. And the problem that we run into is it's an unregulated field. And we have people who get into this quote unquote regenerative medicine mindset who are kind of exposing this sort of chasm of like hope, right? And reality, and preying upon people who might have the money to seek this and create false sort of hype over things that it can't do, and then creating cocktails that really are not tried and true, or making, basically over promising and under delivering. My philosophy is to under promise and over deliver. And I tell patients, there are patients I actually not turn down, but I say, I don't think it's going to work for you. If we are doing PRP, it's a blood, it's just a blood draw and an injection. So, and we're not modifying or adding anything to it. So I have no problem trying. If they are desperate and they're like, I just want to do it once, I will say, it's fine. It doesn't burn any bridges like a cortisone shot, where you have to wait like 3 months to get a joint replacement after, or a shoulder surgery after. So I don't have a problem, but I really sell or steer them away from that when it's not going to work. And that's data. The decisions I make when I talk to patients is data based. Luckily, I've been doing this for long enough that I've contributed to the data and then my own personal experiences with it. And I know who's going to respond, who's not going to respond. And I know what patients that, really have way too much, hope to what might happen. And the reality is it just is not going to work for them.
It sounds like a lot of the times that sealing effect in relation to PRP and what it can help with is related to different degenerative changes within the joint. And essentially it gets to a point where it's just so far degenerative that PRP is not going to be able to touch it that way. Is there anything outside of joint degeneration that PRP is really just not appropriate for?
Well, that's a big question because, there's in orthopedics, for example, there's, a million different pathologies in sports medicine that we take care of. And people will come to me say, oh, will PRP work for my, slip disc or, for my ankle sprain? And, there are people who are doing that. And as a, kind of a shoulder knee specialist, I certainly can't speak to the use in hand CMC joint arthritis or, a slip disc in the back. But I know people are doing it. I don't think the data is there or as robust as it is in the knee and in the shoulder world. And so we just have to be cautious. That's kind of the one thing I tell patients. It's like when we dive into biologics, you want to go to someone who doesn't dabble in it, but you also don't want to go to a place where they use it to keep the lights on, meaning, a regenerative medicine place might charge $10,000 for a product of a cocktail of all these different things, again, with shiny sort of pamphlets and saying the right things to suggestible people who have disposable income for their health. And then unfortunately, I see them sometimes, 3 months later, 6 months later, I said, oh, so how did it work? And they said, I'm no better. And I said, yeah, well, so, because, so you have to look at the motivation behind the place you're going, and you want to make sure you're steered in the correct direction by the provider that is a specialist in that.
And one of the other things, when you mentioned about the provider knowledge, you brought that up a couple of times. One of the things that immediately comes to mind for me is not just the orthopedic provider doing the PRP, but also the knowledge base of everyone else on the team, right? Your PT, your strength coach, AT, and so on that way. Because correct me if I'm wrong, but I believe if you get a PRP injection and then 6 hours later you roll into PT and they heat the dang thing up like with like 20, 30 minutes on a hot pack and heat and all kinds of different modalities, or they cool the thing down with like 20 to 30 minutes of ice and like pneumatic compression with like a cold sleeve and so on that way, like those kind of extreme temperature fluctuations that occur might impact the success of your biological agent that way.
Yeah, so what I do, just to tell the brief thing, and again, we're just talking about PRP, and there is a role of stem cells, and we can talk about that in a sec. But so if you were to come to me for a PRP injection, I tell everyone to be off of the NSAIDs, anti-inflammatories, for 10 to 14 days beforehand, unless needed for life-saving measures like aspirin, and I tell them it might not work as well, but I don't want them to die. And so 10 days of a medicine washout period. Then within 24 hours, preferably within the day we're doing the PRP, I like vigorous exercise. Vigorous exercise has been shown to create more robust and larger platelets. When we look at the megakaryocytes, which are the platelet progenitors, they respond to exercise. So I tell everyone, I say, I want you to exercise as hard as you want the day of the injection, morning of, and then I want you to be hydrated because we draw a fair amount of blood. When we draw the blood, so that's the first sort of prep. The second prep is actually how you draw. They always talk about it's the pull, not the push, meaning a traumatic blood draw can actually basically ruin the procedure. And so we've learned that large bore needles, we use what's called a dialysis catheter. It sounds bad, but it's a 17 gauge needle. I've had it done. I can't tell the difference of a 17 gauge versus a 22 from a shot standpoint. So even though it sounds bigger, we found that size needle as proximal, meaning as far up the arm as you can get, because if you go from distal access, you can have more of a traumatic blood draw, and then that can cause disruption of the platelets before you even concentrate them. Then, so that's a 17 gauge needle. We take 120 cc's of blood. So I won't do 2 joints in the same day because 120 cc's of blood will give us about 4 cc's of platelet-rich plasma. And so anything less than that, because we've learned that the platelet concentration is directly proportional to outcome. So more platelets, better outcome. So we want to have as much as possible that we're putting into the joint. We then combine typically that with one of the byproducts, which is called platelet poor plasma, which has been shown to have this substrate in it called A2M, which is just another molecule that helps facilitate the PRP and what we're trying to accomplish. So in this sense, PRP, as soon as the platelets are injected into the joint or the tissue, they release their products, they release their granules. And within the platelet granules, those are the workhorses, and those are the growth factors that we're looking for. There's over 1,100 proteins that are actually in those granules, and that's what goes to work. Post-injection is also important. Like you said, we actually have our patients use heat, a heating pad wrapped around the joint for 20 minutes twice for the first 48 hours. So for the first 2 days, I like 20 minutes of compressive heat on the joint because we're trying to increase the blood flow to the joint. And then after that, the patients can do ice if their knee is sore or whatever. And we ask that no vigorous exercise for minimum 2 weeks. Some people actually will push it all the way to 6 weeks. I think 6 weeks is excessive. I've never seen a study showing me 2 versus 6, but we try not to have an inflammatory environment. And that's when you get a patient saying, well, can I play pickleball or can I do this? I'm like, this is your money, and I'm telling you how to have the best outcome, so if you get the shot on Thursday and play 6 hours of pickleball on Saturday, it's not going to work. So save your money, spend it on a new pickleball racket. And so, the post is as important as the during, and which is as important as the pre.
Absolutely. It sounds like you take one small step back from an activity level standpoint in the sense that, yeah, you might have to rest for 2 weeks and avoid vigorous activity, but that 2 week small step back combined with the effects of the PRP allows you to make leaps and bounds moving forward, which I feel like would be especially beneficial for the individuals who just feel stuck in
Yeah.
their case and stuck in their care, where they're trying different things. They've tried the PT, they've tried this, they've tried that. Maybe they've even dabbled with some of the more newer treatment options. Maybe they've tried dry needling or whatever. And it's
Right.
like, they're not getting the outcomes that they want. So it's like, hey, look, sometimes we have to step back in order to progress leaps and bounds forward. As you were talking as well, you brought up stem cells a few times, and obviously those are drastically different than the PRP that way.
Right.
And same thing there. I've heard individuals that swear by them for any and every benefit that you can think of, whether that's anti-aging benefits or whether that's the joint health and longevity. I mean, there's certain individuals like these biohackers out there that are promoting, stem cell injections every year nowadays. And it's like, I don't know where we draw the line with stem cells as far as what we need versus don't need, what's enough versus what's too much that way. I'm interested to hear your thoughts. For those listening, what are stem cells? What are kind of the goals of injecting stem cells from an orthopedic standpoint? And what's kind of the overall hope and use application of those stem cell type treatments that way?
Yeah. So stem cell, in essence, the stem cell is a cell that is a kind of early along the cell development line that can be signaled to become different cell lines and then hopefully make the product of that cell line. And so when you're doing a stem cell type treatment, you have to have the cell, but then you also have the signal to make that cell do what you want it to do. So stem cells in and of themselves come from basically the two sources in the body, bone marrow and fat. And so there is a treatment that is called a bone marrow aspirate concentrate, or BMAC, where typically we go to the pelvis and we take bone marrow from the pelvis and we'll concentrate that and inject that to either a repair site or an arthritic joint. The other way is there's a technique of using fat. There's one called Autopose, which is the Arthrex product, and then there's Lipogens, which is another product, and it has to do with how fat is micronized. So fat is harvested and then micronized or prepared, meaning made really small, and with the hope that it is releasing the mesenchymal, they're called mesenchymal stem cells, to the point of repair. As we've learned, everyone says stem cell, they're actually signaling cells. So instead of it being a stem cell that can become any cell, what these cells are actually doing at the microscopic level is a chemoattractant. They're attracting type of repair cells called paracrine cells, and what they're doing is these are cells that are wrapped around the blood vessels, and they're signaling this to do whatever needs to happen in that environment. There's a certain pathway after something is injured of an inflammation phase, a repair phase, and a remodeling phase, and the goal is to kind of help boost that along. So there is no stem cell, no matter what shiny pamphlet from any sort of person trying to take $10,000 of your money, that will actually rebuild your knee or rebuild your shoulder or repair your rotator cuff or do these crazy things. It's just not science. There's no data for it, and it just doesn't happen. What it does do is it makes things feel better for a period of time. And so when you have pain relief, sometimes pain relief means better function, and there's this conception that maybe it healed, but it didn't. It just made you feel better for a period of time. So then we take these patients who had PRP and compare them against something like viscosupplementation, which is the gel injection, and we take PRP and compare them against people who have had bone marrow aspirate concentrate, and we compare them who have had Lipogens or Autopose and say, okay, well, who is the winner of this race? And I'm just talking about like knee arthritis and shoulder issues, right? And PRP is the winner of that race. So even though someone may swear by it, you got to remember that when you have buy-in, like if you get something for free, you don't really kind of treat it like if someone just gives you a pen, you lose the pen. But if you went out and bought a pen, you would covet that pen. And so if you spend money on a product, you want it to work. And so no one wants to say, geez, it just didn't work. I wasted $10,000 when their friend, got a PRP shot for $700 and it worked perfectly. But that is sort of the outpatient non-operative use or sort of overview of the different cell lines and the different treatments. But everyone calls everything a stem cell. And so part of our first appointment is education. Second use of this, and we can dive into this if this is where you want the conversation to go, is how we use it in the OR to optimize, our surgical treatments.
Absolutely. I'd love to hear more about that, because when you mentioned about bone marrow aspirate, I kept going back in my mind to that concept I mentioned early on at the start of this in relation to the meniscus repair. And I'm like, I wonder if that bony tunnel is releasing some of those factors that you derive from a bone marrow aspirate into the joint, and if that's the mechanism there. So I'd certainly love to hear more about what you call even the OR as well, and successes you see from that.
Thoughts of using biologics in the OR to optimize our outcomes. And so we'll start with the ACL, and the ACL, when I do an ACL reconstruction, we do sort of a biologic augmentation to it. So if I'm doing a autograft, which is from the patient versus allograft, I want to optimize it best I can. So one of the things we do is intraoperatively, we'll take blood and make PRP and soak the graft in and impregnate the graft with PRP. We use a special solution, calcium chloride thrombin, and then PRP, which has been basically activates the PRP and does a couple things. Number one, it works as an surface antibiotic, so it decreases the chance of any sort of graft infection. The second thing is it hones or attracts the healing processes of the body. So we see improved and faster integration. Not faster, I'm cautious about that to say that if you get this done, you're going to be playing football 3 months later, but faster in that we're seeing more robust healing in our tunnels and better vascularity of our grafts. Then, if we are doing meniscus repairs, for example, we will often do biologic augmentation of that. For example, actually yesterday in the OR, we did a horizontal cleavage tear. So the meniscus kind of is split like that. And so we close it and we want that to heal, but those two ends are not always just sticky to each other. We have to kind of cause a reason for it to stay. So even though I put sutures and try to compress it, before we when we have it compressed like this, we actually will then take a needle and impregnate that space with biologic, in this case PRP, in there to kind of biologically enhance. We get to the problem that, of course, we want to use this all the time, but it is not covered by insurance. And so there are places that will say, do you want PRP or do you want bone marrow during your surgery? $1,500. We, for better or worse, from Peninsula Orthopedics and where we are, I believe more strongly in my outcomes, and I'm less worried about the few $100s that we're eating during the surgery. Patients don't even realize that we sometimes are even not even generating money from a surgery because I use so much of this crazy stuff, because I much rather have my patients doing well than not. And so it's a very interesting thing that patients don't necessarily know here, that when we're using this biologic augmentation techniques, they're getting it for free. I had a surgery out in California by my mentor because I had a big hole left in a big cyst in my tibia from I had 4 ACL surgeries. And so I was left with a big gap, and it was very painful. It became a stress fracture and standing all day like we do. And so a procedure we do, actually, we kind of developed it together, is something called intraosseous bioplasty, where we'll inject a mixture of bone marrow concentrate and bone to fill this void. When I went out there, when I was signing in at the surgery center, I'm standing there with my glasses, I'm MPO, and I'm getting ready to have surgery. They're like, "How do you want to pay for your bone marrow concentrate?" And I was like, my credit card, I got to go to my car. And whereas we just don't do that here. We just sort of do what we do because, we're in a situation where we run into our patients everywhere, and I'd much rather have happy patients than pissed off patients. but yeah, so intraoperatively, it comes to this concept of a cell, a signal, and a scaffold, where we have to have the cell, which we're trying to get. Sometimes it's a mesenchymal stem cell. Sometimes it's a bone, cell or an osteocyte. And we need a signal to wake it up, and then we need a scaffold to hold it there. So that's the kind of holy trinity of intraoperative use of biologics: cell, signal, scaffold. So when I do cartilage transplants, oftentimes we'll make a little slurry of things when appropriate. I'm doing one tomorrow that we have, we're going to use intraoperative bone marrow concentrate mixed with allograft and a fresh osteochondral allograft. So we've got the cell, we've got the signal, we've got the scaffold. So when I go into the OR, that is the holy trinity of biologics: cell, signal, scaffold.
Quick break, because if you're a rehab professional sick of burnout, this could be your answer. Engaged Movement's blended practice model is a proven system built by Dr. Ray Gorman, a PT who walked away from the 55-hour-a-week grind and built a blended practice model that doubled his income while working less than 25 hours a week, and he didn't have to rely on the traditional way of selling sessions to do so. It's all about blending remote and in-person services, stacking monthly recurring revenue, and building a business that finally supports your life, not the other way around. This model isn't just theory. Real providers, including myself, are creating lives of freedom and flexibility without being tied to their schedule. And as a listener, you get free access to the complete training. DM my name, Dan, to @RayGormanDPT on Instagram and receive your free breakdown on the model. That's incredible. And that makes so much sense when you outline it like that. And I love to hear about how you integrate that into the OR care. And I mean, huge respect to you and the entire team at POA for the approach that you use in relation to kind of your focus on outcomes that way. That's absolutely incredible. And one of the things I want to kind of build off of on that is I've seen a number of different meniscus repairs from you all clinically. They all do phenomenal, but one of the things I've noticed is the majority, in fact, I think all of your repairs that I've seen have been all inside repair techniques.
Yeah.
They're not inside outs. And it's like, I know there's a lot of individuals out there that still make the case for the inside out, but in my mind, I'm thinking additional OR time, additional tissue dissection. And it's like, with the work that you do within the joint space that way, and with the incorporation of biologics, you're getting a phenomenal outcome. The meniscus repair holds, it's stable. The outcome is successful by all intents and purposes without the additional OR time, without the additional tissue dissection. And so on that way, it really just streamlines that process, in my opinion. So
the only time I'll actually do an inside out is typically with a meniscus transplant where we have to. But an isolated meniscus repair is a challenging thing because the meniscus doesn't have a great blood supply. So even, by isolated, I mean not associated with another knee surgery, an ACL. So we see the literature shows about a 15% failure rate for meniscus repairs in an isolated setting. However, that data is older data because now we're biologically enhancing it, and we're not seeing as many re-tears. The compressive devices, or the all inside devices that we use now, we can do the exact same kind of orchestration of these sutures. I can put them vertical matches, I could do oblique, I could do horizontal matches, I could do whatever shape I want, and I don't have to make an incision in the back to feed sutures. And so these devices have been shown now to basically outperform inside out. Of course, sometimes when you repair menisci, you have to be ready for all of them. So when I tell a patient, we're going to repair your meniscus, I'm ready for, we have basically 4 different ways back in the OR to repair them. And I use whatever I need to do to get the job done, and to optimize the outcome.
I'm interested. I see a huge rise in the use of an IT band tenodesis to help with those ACL reconstructions. Obviously, you touched on the ACL graft itself and the meniscus tears that might present with them and how you incorporate PRP into those. Are you doing anything with the PRP in relation to that IT band kind of tenodesis graft on the extra-articular lateral component of the knee joint that way?
Yeah, so the LET procedure, lateral extra-articular tenodesis, is been shown to basically augment our ACL reconstruction outcomes and to diminish re-tears. So that's why just about every ACL I do nowadays has this procedure associated with it. When I'm doing autograft, meaning I'm using the patient's own tissue, so their IT band, I don't need to augment that biologically because I'm putting their own tissue in their same environment to their same and own bone. So there's no real reason to biologically enhance in that component. When we start using allograft or donor tissue, I do use it because, to me, I call it's like a biologic handshake. It's saying to the like tomorrow, we do this fresh osteochondral allograft, I am going to soak that graft, which is a donor graft, in the patient's bone marrow concentrate as an introduction, essentially, before we put it into the knee. And then that will sort of help that interface between the allograft and the host bone.
That makes a lot of sense. I'd imagine that concept of using the PRP to kind of make that metaphorical handshake occur between non-native tissue, like donor tissue that way, and the patient's biology also carries over to some of the other procedures. I think of some of the different like patellar stability procedures I've seen done that tend to be using donor tissue, and I'd imagine this would be a great way to continue to kind of build that metaphorical handshake and ensure that tissue is integrated in a means that it should be.
Right, exactly. Yeah.
Absolutely. No, that's incredible. And again, I really love the work that you're doing in the OR that way. And I have huge respect for you and the kind of approach and philosophy you're using, driving patient outcomes first. In relation to the shoulder, obviously we've talked about the knee, but I'm thinking about the shoulder and some of these other kind of procedures I've seen up there. Again, tend to be more on the stability side, whether that be labrum repair or something along those lines. We're not necessarily introducing donor tissue into the shoulder the majority of the time. So do you still incorporate PRP type procedures into the work that you do in the shoulder, or is it less frequent there because it's not necessarily introducing new tissue into the joint space?
Good question. When we're doing, let's say, rotator cuff repairs, we want to, the tendon is pulled off the bone, so we need to put it back on. Oftentimes, by the time a patient presents to us, even though we may have recommended surgery a few years ago, they present with tissue that is no longer freshly traumatic. And so we want to repair this tissue that really isn't so high quality. So then we say, well, how can we augment this tissue to improve the interface of the rotator cuff healing to the bone? So that's where we have to go a little more structural. There's a procedure that we do called cuff mend, where we do a repair of the rotator cuff down, but then we take a sheet of allograft tissue, it's actually skin cells, and lay it on top of the repair. and hold it there to help that interface of the tendon back to the bone. And so the actual like injection of PRP or injection of bone marrow into the surgical site does not have the power that the structural reinforcement does with this Kaufman procedure.
Interesting. No, that's really great to know. And I think it's really interesting too, because a lot of the times when I hear about some of these different orthopedic procedures, I don't think I fully understood or grasped the biological healing components and the things that are being done to evolve those healing timelines, like this incorporation into the OR that way. And it sounds like a lot of these are just kind of one time done in the OR, and then we don't really revisit it with any additional biological intervention in the past. And even when we were discussing it in relation to non-operative kind of cases that way, like the 53-year-old knee case that we were discussing earlier, it sounds like PRP tends to be a one-time thing. It's not like something that you do 3 or 4
it's actually
times throughout the
longitudinal.
year.
No, it is that. So I call them biologic boosters. I will tell you, once I start PRP with someone who buys into it, it tends to be, usually once or twice a year. And so it's not always a one and done, intraoperatively, obviously, but once we do a cartilage transplant, I want to make that knee or that shoulder, vibrant for its entire existence as long as we can. So these periodic or episodic biologic boosters do have a role to longitudinal care as well. Sports medicine and joint preservation is vastly different than replacement. You get a new knee, a new hip. It's a great surgery. I don't do that surgery, but it's a great surgery. But once you get it, you're sort of done. For us, we're trying to maintain the joint. It's like a lawn, right? You don't just fertilize your lawn once. You fertilize it, multiple times through the year. And so we're trying to keep this lawn going as long as possible, and we have to keep the soil healthy and we have to keep the grass healthy. And so sometimes it requires treatments of the soil, and sometimes it requires treatments of the grass, and sometimes it requires fertilizer. And that's where sort of this Miracle-Gro or PRP comes into play. So it is longitudinal care, not usually one and done.
What kind of things can people expect after they get their first PRP injection that way? Are they, expecting like a lot of different pain? I know we talked about kind of that 2-week kind of quieter window that way following an injection, but what does this kind of procedure cause from like a side effect standpoint for the person that's never had it done before, doesn't know what to expect on day one?
That's a great question. First of all, first and foremost is it has to be an accurate injection. So oftentimes we will use ultrasound to be targeted to make sure we're precise. Gabe Ellis, a PA that works with me, is an expert in ultrasound injection. So when it becomes a sort of a complex or a different joint like the hip, or we're trying to get into the actual joint of the shoulder, we will use the ultrasound to make sure we're precise. So precise injection, number one. Number two, I tell patients, you are getting a shot that will not feel like a cortisone shot. Cortisone shot, you feel good kind of quickly because of the lidocaine. This takes 6 weeks to kick in, really, and it sneaks up on you. You'll be thinking around week 3, it's a little better, but maybe it wasn't worth it. Then all of a sudden, 3 weeks later, you go to do something that you used to do with pain and it doesn't hurt. You get a little scared. You're like, oh my gosh, am I lucky? Is this working? And then you do it again, and then you do it again. You're like, holy cow, it's working. And so it sneaks up on you. So patients have to understand that they need to be patient with this process. You don't spray Miracle-Gro and your grass looks better that afternoon, right? So, but they can have pain from the injection. There are some people, I inject their knee and it's like they never even had a shot. I get it. I get this shot and I don't feel it. There are some people who get the shot and they are miserable. It's just, and there's no way to predict it. That's not common, but we do the shot at our surgery center, POA Surgery Center in Salisbury. The nurses there we've got such a vibrant biologics program that the nurses are so skilled at setting it up. We have a kind of in the pre-op bay, there's like a little private area. The patient comes in, whatever snack you want, because it's the surgery center. You kind of sit there and the nurses draw the blood. The blood never leaves your site. It's processed with the machine right next to you. So you get to experience that and watch it happen. It takes about 20, 25 minutes for that to happen. And then I come out, between cases, usually try to make it that we have a couple minutes to chat and while the blood is kind of finishing up, and then we do the shot. And again, sometimes patients just walk out as if they never even had pain. And then sometimes it really hurts, but I like the joint exercise right after it. So I like the joint reactive force to distribute it. So if I inject you in like a superior lateral or above your kneecap, because that's the easiest way to get into your knee, I want you to stand up and give me 5 air squats afterwards to help distribute the PRP throughout the knee. Sometimes I'll inject it through a medial portal, and sometimes I'll inject it through a lateral portal. It really, the knee sort of tells me. Not every knee is injected the same way. And so I kind of examine you before I do the injection to ensure that we can get the PRP in the most accurate and pain-free way.
Has there been any really like hallmark or unique cases and applications of PRP injections that have come up in your clinical career thus far, or anything that you're like, hey, we kind of went a different path than normal with our application of PRP here, and it turned out to be a huge success for this specific individual?
Yeah, I will use myself as an example that I'm blown away at the outcomes because I'm 54. I have a 4, ACL left knee. I've never slowed down from an activity standpoint, from a functional training. 4 ACLs done on my knee. I don't really have joint space narrowing, but I get, weight bearing pain. And I don't slow down. I love to surf. I love to, ski and backpack and do backcountry and mountaineering. So I am the hardest patient to manage. And I'm blown away how my pain goes to a zero about 6 to 8 weeks after I have PRP, and I get it twice a year. I pay for it too, and so I would say I am a good success because I'm a challenging patient from the standpoint of my desire to be active, but also my what I have going on in my knee. Intraoperatively, the thing that kind of blows me away with PRP or BMAC in the bone space, when I'm treating these huge cysts or insufficiency fractures or avascular necrosis, that I can take a joint that's about to collapse or a joint that has just such horrible cystic changes in the bone, and I can impregnate it with bone marrow concentrate and bone graft, and I can fix that problem. That blows me away when a patient, can barely walk on crutches, and then they come in, 2 months later and, walking, feeling great. And then finally with PRP, so that's bone marrow concentrate PRP with ACLs, doing this kind of biologic augmentation of the ACL. I had to go back and look at one that was about 6-8 weeks post-op for stiffness, and the ACL was already looking vascularized, meaning it had a good blood flow to it. And so that just locked it in for me. And when I give talks on this, I show the intraoperative picture 8 weeks post-op of this blood flow to the ACL, and that's because it was biologically augmented.
Absolutely. No, that makes so much sense. And it's so great to kind of see the biological element kind of pushing the frontiers of what we've come to know from an orthopedic and sports medicine side of things. And it truly makes me excited for what the future holds in this space that way, because we're just scratching the surface right now. It's like, in 10 years, the biological healing timeline and accelerations that we're going to see is like nothing we can imagine right now. And I think the work of phenomenal individuals and clinicians such as yourself really lays the foundation and makes that possible. And again, it's really the next frontier here as far as I'm concerned, as far as what is possible in relation to some of these complex sports injuries, right? Take the ACL. It's like, I've seen everything from hamstring grafts to quad tendons to patellar tendons. We can only choose so many more tendons in the body. At some point, we just have to start biologically enhancing those tendons like you're doing that. I think it's phenomenal work to see next frontier of this from an orthopedic and biological medicine standpoint. I feel like we could probably talk about this all day long and just scratch the surface because there's a lot that goes into it. And, you brought up so many different things earlier that we could go into as deep dives as well, from the cellular concentrations to and so on that way. But for people listening that way, is there any kind of closing thoughts you have or remarks or anything that we missed in our discussion thus
I
far
think
today?
the most important thing is, if you're considering, if you're a patient that's considering a biologic treatment, is to go to a specialist that has an understanding of it. There's misleading kind of advertisements where these centers make these wonderful claims, regenerative medicine places, and they're not really what they are claiming to be. So I think the most important thing, just like if you're going to buy a car and you research it, is if you're seeking a biologic treatment, is to research the people doing it and whether they're familiar about it and what their outcomes are. That would be my biggest piece of advice is making sure that you are a good consumer before you consume.
Absolutely. That makes so much sense, Dr. Scopp. And for people listening who want to find out more about you and your orthopedic practice and so on that way, where can they find you all at?
So our website's peninsulaortho.com. We're Peninsula Orthopedic Associates, and that's probably the easiest way to kind of look into us. I've given a fair amount of lectures of this around kind of the country, and some are on YouTube. I mean, if you just Google, Jason Scopp and Biologics, I could probably bore you to death if you're not bored from this already. But more important is you're using your own money to do this because it's not covered. And so just be a good consumer when you decide what treatment to get.
Absolutely. I love that. And we'll link to Peninsula Orthopedic website, your Instagram handle maybe, and then some of those YouTube talks that you mentioned as well in the description. That way, if you want to find out more and get in touch with Dr. Scopp and his team, you can just click there and find all that. Dr. Scopp, this was amazing. I really appreciate your time. Thank you so much for your insights, man.
Yeah, man. Thank you.